Hi, and welcome to Faculty Focus, a podcast supporting the clinical education community in Leicester. We bring you Educator CPD, showcase new initiatives, and shine a light on some of the faculty behind it all. Hello, everybody, to this episode of the Faculty Focus podcast. And today we're going to be talking about GP training, and specifically GP training in a hospital environment in UHL. And today I'm being joined by Laura Taylor, who is clinical tutor for GP training here at UHL. Laura, do you want to introduce yourself? Just tell us a little bit about how you got into the role and maybe some of the stuff you're involved with in UHL with regards to GP training.
Hi, Andy. Nice to speak to you. My name is Laura Taylor. I'm the GP Clinical Tutor, like you said, in UHL. Looking back and thinking about how I got into that role, I'm a GP by training. I'm a Leicester graduate, trained in Leicester, did my foundation jobs around the country like everybody, did a year of psychiatry training and then GP. Working as a GP during the pandemic made me realise that it was really tricky to do medical education and work with our registrars at that time. And I became really interested in medical education. How do we change that? How do we keep making sure that our standards are high and that we're producing people who have the best training opportunities possible? As part of that interest, I applied for a job at UHL, thinking I might go in here and see how I get on. So it was a clinical teaching fellow job, so not technically one that was made for GPs. But I got the job and I did it for the year. They helped me get my qualifications in education, or medical education. And following that job, a position was available in UHL for the GP Clinical Tutor. So I applied and I was appointed to the role. Been doing the role approximately 2 years now and loving it. I'm loving the fact that I can bring GP awareness up and that I'm able to come back to a hospital that group of hospitals that I've trained in myself, see familiar places, familiar people, and just help raise the profile of GP training a little bit.
Excellent, yeah. And so GP training is, for those of us that haven't really been in medicine or are not up to date with GP training, so how is it that GPs end up in UHL or in hospitals? What's the program involved and why do we see them?
Okay. So GP training has been changing a lot over the past 5 to 10 years, particularly. We see GP trainees in lots of different areas in UHL. Classically, if we were to go back to when I was a lass and when I did my GP training, you would do your foundation program. You would then choose a specialty. Sometimes people like me possibly chose something different for a couple of years and then came back. But generally, people had just done foundation program or a couple of years of specialty training before coming to do GP. At that point, GP training was 3 years. It was known as VTS, and you would be rotated between hospitals and primary care posts for those 3 years. You had 2 exams to do, and another part of the assessment is getting your portfolio done. Once that's done, you'd be signed off by the Royal College and would get your CCT and GP. Now it's slightly different. So we have a really changeable profile of trainees coming through at the moment. We have higher numbers, of trainees who've done something before. So we have quite a lot of trainees who have come further through specialty training in another specialty before making a decision to come to do general practice. We also have much higher number of international medical graduates coming to do GP training, and they bring their own interesting medical backgrounds and experiences to the role. Essentially, I think what I'm saying is that the GP trainee population in UHL is wide. The variety is wide. They have a variety of experiences. I don't think there's a one-size-fits-all description of them. All have got medical experience. All have been signed off as foundation competent before they can get into the program. I think the best way, ask them, speak to them, ask them what they've done. You'd be surprised. Some very interesting pathways.
Yes, yeah. And so the program is still a 3-year training program, but a year or 18 months of that is in hospital type of environment or one of those specialties before you do specific GP placements. Is that right?
Yeah, so it's again changed relatively recently. So the classical 3-year program it's still the bulk of GP trainees. So people are coming through doing a selection of hospital jobs, a selection of primary care jobs in their first 2 years, and in the 3rd year they're placed purely in general practice. And that tends to be one practice that they spend a year in as well. There are people who are slightly different. So we have some academic clinical fellows, we have some 4-year posts, but those tend to be the minority. The majority of people coming through, so at the moment where they are reducing, so the Royal College is reducing the number of specialty posts, which means by default less time in secondary care. So at the moment we're working towards a 24-month versus 12-month primary care to secondary care balance. It doesn't always happen perfectly. It's not always specifically just that exact number of months, but that's what we're aiming for. So generally that means they get a year, over 2 years in secondary care or an equivalent community post, for example, psychiatry.
And the sorts of placements they're doing in HL, I mean, I have to say I don't really see them that much in anaesthetics, or can't remember seeing too many when I was doing ITU as a registrar. But so there must be some specialties that you tend to see them more in than I would imagine.
Absolutely. No, you're quite right. So we have no GP trainees in anaesthetics or ITU at the moment. So the thinking is that these are training posts. How do we make sure that they provide the training that a GP will find useful, that they will need, as well as providing the service and best service that we can as a trust. So generally, with the most GP trainees at the moment are in accident and emergency, or the ED. There are quite a few in paediatrics, quite a few in general medicine, quite a lot in acute medicine roles. Those tend to be the bulk of it. We have obstetrics and gynecology jobs as well available. And then we have a selection of the smaller specialties. So we have ophthalmology jobs that GP trainees can take as a 4-month rotation, ENT, so things like that are available, but not in as many numbers. So they tend to be the ones that people are quite keen to get. So they're quite prized.
Indeed. And so what sort of things are GP sort of bringing to, so, if you're overseeing a department or you're supervising a department with GPs in it, what sort of things, what are the benefits of having GP trainee? I suppose we're calling them residents now. I just saw a recent communication from the BMA, the government about the terms we use. So GP residents, what are some of the advantages of having these types of doctors within our team?
I think having a GP resident in our team is an invaluable experience. I think the experience that they bring, that knowledge of primary care, the knowledge of the structure with secondary care is so important, and passing that on. So I think, yes, they come to learn, but also we can learn from them as a trust as well. The understanding that they bring of community services, how to discharge people, how to work with people, how would this be followed up in primary care is all really useful for us to learn as a trust. But also we're then teaching them what would be the best way to manage this person from our perspective. So for example, from a diabetes perspective, how would we have expected you to have managed this before doing an advice and guidance letter? How would we have expected you to seek help? So just learning those routes, those pathways that they can use would be incredibly helpful for both sides.
My wife being a GP, I certainly hear a lot of sort of gripes about sometimes some of the discharge paperwork and some of the sort of expectations that, secondary care have of primary care and vice versa. So there's always a little bit of conflict there. So anything that can sort of cross-pollinate understanding about, what can we do in the community, what can we do to help things in secondary care, just to kind of share that burden. Because some of the stuff sounds ridiculous. Some of the kind of paperwork involved sounds really silly.
Absolutely. Yeah. I think having that team around you, cross-pollination, knowing the people that you worked with in the hospital, you're going to know them when you're out in the community as GP, when you're fully qualified. You know who to refer to. They know you. And just all of these things that we learn without actively trying to memorize it, that is something that's really something that they can get from working at UH.
Yeah. And so when it comes to the supervision of these GP residents, then what sort of challenges do you tend to find, obviously in your role as clinical tutor for GP training? Is there sort of particular problems that you find, or things that need to maybe raise awareness of different aspects of their supervision or training within different CMGs, different departments?
Yeah, absolutely. So as a GP trainee or GP resident, they will have an educational supervisor. Their educational supervisor is an overarching supervisor for the whole 3-year program, or 3-phase program, we should say, because quite a lot of people will have time out or do program experiences for various reasons. So that educational supervisor will be based in primary care. So it tends to be the GP who is the supervisor within the practice that they will end up in ST3 if all planning works out. Their supervisors in secondary care are clinical supervisors. So they will be first port of call when in a secondary care post, but they always have that backup of the educational supervisor as well. So they'll never have an educational supervisor based in secondary care, which can be quite confusing, particularly when people start and their ST1 post is in UHL, in a department within UHL. They'll ask me who is my educational supervisor, and I have to defer that one and send them back to the GP programs team to say, this person's asking this, I can help them with clinical supervisor. But so it's a...
I guess they have their own portfolio requirements. So if you have a GP resident on the team, then are you trying to change the type of learning they're having with a kind of primary care focus, or really just treat them like anyone else on a rotation, picking up the things that everyone else would need to, whether you're on an ACCS program or a surgical teaching program or a medical training program? Is it, or are there specific things you need to be thinking about when you're supervising these individuals clinically?
Yeah, I think it needs to be a bit of both. Sorry for the vague answer. I think there are generic skills that all doctors have and need to have and will be learning throughout their lives. So I think that needs to be considered during their training. That thinking about the clinics, how's a clinic structured, communication skills, how do I speak to a patient about this really complex disease? These are things that we all need to know. Some places have, or I've had discussions with some places about whether it's appropriate that GP trainees be in specific areas. Is this relevant to their training? Shouldn't this area be better by a specialty trainee in that area? And I think that it has to be taken as an individual specialty and individual trainee or resident case-by-case basis, really. I think if we have people in, for example, off the top of my head, obstetrics and gynecology, we have GP trainees who are rotating through there regularly. A few of them have got vast experiences. Some of them have come being obs and gynae registrars in another country. So they're going to be starting at a different level, and that needs their training, their learning has to be tailored to that. That said, they also, because they're training to be a GP, they shouldn't be doing exactly the same as the obstetrics and gynecology trainee, even if they could do it previously. So they need to learn how to adapt that. And I don't think that's something that needs to be put onto the trainers within UHL. I think that's something that needs to come from the trainee to say, I'm a GP trainee. These are the opportunities that are available for me. How can I make them work for me, considering the career that I am now working towards? So I think being able to provide them with a list of opportunities is helpful, but I wouldn't try a one-size-fits-all approach. I'd just speak with them, work with them. What's their experience? Where are they going to take things? And what do they need? One of the top tips that I give them when they start, so for every specialty that there is a GP trainee in, apart from ophthalmology at the moment, we have a RCGP curriculum booklet that's been tailored specifically for University Hospitals Leicester. So we have a departmental GP curriculum booklet that has lots of details about where the department is, what floor it's on, where the toilets are, but also in depth, what actually do you need to get out of this as a GP trainee and how can you do this? And they've all been written by trainees or residents who've been working their way through the rotations. So it's people with feet on the ground picking up top tips for how do I do this? Where can I get the access to the learning that I need to become a better GP when I get my CCT or move on from this rotation?
Yes, I was going to ask actually whether there was a sort of specialty specific like opportunities, like you said, learning outcomes or opportunities for each clinical specialty, because it does feel like, if I was supervising someone in a particular specialty, I think it'd be quite useful to have that list. But it sounds like that's been incorporated within a sort of wider induction package for
it has,
those GP residents, and probably really useful for those supervisors in those areas to have those first meeting conversations about what do you want out of this 4 or 6 month block.
Yeah. So what I do, I get a list of who is coming to UHL around 2 months in advance. And at that point, I send them out an induction pack, which is an email with a list of resources, a link to a Padlet that I've created called UHL GP, rather uninspiringly. But it's got lots of information that they need, and it also has all of the curriculum booklets attached to it. And I advise them to go through those in detail, go through the ones that are relevant to them, also to take them with them to their first clinical supervisor meeting. And one of the first things I say in the email is you will need to have made a clinical supervisor appointment as soon as possible. As soon as your feet hit the ground, essentially, you need to be doing that, because that then opens up the opportunity to write a PDP. And with a PDP, you're then armed with this is my plan. And you can then say, I'd really like to go to that clinic. It's in my PDP and I think it would be really helpful for me. So it's encouraging, giving them the tools and encouraging them to use them for their best game that they can.
I'm not sure, I haven't really asked this, but what sort of numbers are we talking about within the trust at any given time? How many GP residents would we have?
It varies very much, actually. Sometimes, depending on season, I can't quite get the pattern of it, depending on when people come. Generally, we've got around 80. So there have been times when we've been down at around 50, other times above 80. But I think as an average, it seems to sit around the 80 mark. And they're scattered. So I think the biggest groups tend to be in A&E, like we said, and there can be around 12-ish there. But there are sometimes GP trainees or GP residents or working as a sole GP resident in somewhere like ophthalmology or ENT. You find them everywhere.
So it can be. So I suppose that's where you really come in, is because you may not have that community of peers around you, like in AD, and that's where you come in, is sort of make sure that people aren't lost in the system or floundering. They've got someone to kind of go to on the ground. And I suppose that sort of leads into the other question I had, which was where you sit within the kind of, I guess there'll be college tutors or similar, and then also TPDs. So do you have a clear remit about what you do and what they do, or is it that you all kind of all work together to sort of solve problems?
I think we work together. I have a clear remit. So when I took this job, I knew that I would be working with ST1 and 2 GP residents. After taking this job, then also started working as a TPD for GP training as well. So at that point, I was given the option of what year group would you like to TPD? So I TPD the year 3 group so that I can see them go the whole way through. And also it doesn't muddy the water between my UHL role and then my TPDing role. But having done the TPD role, I'm aware I know the ST1 and 2 TPDs as well. I trained with quite a lot of them. It's a small world in medicine. So yes, I tend to work very closely with them. If I've got a question, I'm happy to email them, text them. They're happy to be emailed or text, and vice versa. If somebody wants to give me a heads up about there's somebody coming to UHL who has got a specific need, they will quite often pass that to me, and then I will pick that up and take them forward from there. So it's developed in quite a fluid way, just with how I've picked up jobs, how other people around me have worked, and we've become a team that works apart but together at the same time. I think it's probably
well, that's really interesting. I didn't realize you had that TPD role, but yeah, I can see how that they kind of work sort of in synergy. I would imagine that that must be really helpful for you to know that part of it as well as the local side specifically. Absolutely. As well.
So helpful to finally be involved in things like ARCPs and to understand the detail of things that need to be put into portfolios so that I can start encouraging it early. And then by the time people are coming through ST3, I can see that, yes, we're getting there. And yeah, it's lovely to see people working their way through from meeting them at ST1, writing a specialty booklet, curriculum booklet, and then coming right through to assessing their final exams and being signed off with an outcome 6.
Absolutely. Must be really, really satisfying. Well, just thinking of sort of drawing this to a close, I know you've got a rugby tag tournament to get along to, so we'll think about wrapping up. So where can we find out a little bit more if listeners wanted to find out some more about what you've been talking about? Where can they go? Who can they contact? Are there any sort of specific challenges you kind of wanted to highlight for our listeners?
Yeah, so I think first stop for any questions general practice related would be the Royal College. Their website has got a really great section on GP training, the changes, why these are happening, where you expect GP trainees. They also have the Royal College curriculum booklets as well, which are broader, less locality specific than our ones, but they're helpful, and they will give a guide as to what is expected of a GP trainee or a GP resident by the time they've finished a job in this area, or by the time they've finished studying in that area, because some of them just don't get jobs. I mean, there are not enough jobs. You can't fit in the time. So they are also going off to learn things on their own, to go to clinics, try and book things in. So just, you may encounter them coming to clinic, you may encounter them as a doctor working within your department. So Royal College would be the first port of call. You can have a look at the Padlet that I've made for NHSG or UHL NHS GPs. It's got lots and lots of information. It's more focused on local guidance, but again, that's what we need in UHL as well. And I send that out to every GP resident with every induction welcome email that I send every 4 months. So there's no excuse for them not having it and not having awareness of it. But yes, I'd be happy to send that out to anybody that wanted to have a look at it, or post it somewhere if it would be something that would be useful. Thinking about where else can they get help. If any GP is struggling, any GP trainee is struggling, then contact me. I'm around to just run things by, if nothing else, even if it's a question about filling in a portfolio. I'm doing a clinical supervisor report and I'm not really sure what to put here. I'm around. I can get into the system. I can sit and go through it and work and sort of help puzzle that one through as well. But yeah, I'm open to contact for any questions, any help that's needed. I'm here.
Well, that's really good to hear. Yeah, I guess well, anyone who's at UHL, they can find you on the email address book, so they can get your email from that. And I'll stick the link into the show notes so that people can access that website at the Royal College of GPs to find out those specialty specific booklets, which I think a lot of people, if they haven't heard about it, will find that really useful in those early conversations with GP residents rotating through. So
can I do
stick
a plug
that in the show notes. Well, yes, of course, by all means.
So my booklets possibly need to be updated now, and I generally encourage people who need to do a QIA, which is something that a GP doctor who is in training can do when they're in secondary care. So if any booklets or anybody is looking for a QIA, asking their clinical supervisor, have you got any ideas? There are a few projects going on in the Department of Clinical Education that they would be welcome to dip their toes into and see if that's something that they'd be interested in taking further.
Excellent. Yep. Yeah, absolutely. Always good to sort of signpost those QI projects, but particularly ones that are up and running and,
Exactly.
already, because it can be a really difficult thing to sort of tick off on your ARCPs. So absolutely. Yep, absolutely. So contact Laura if you would like a QI to do with improving those specific booklets. Great. Okay. Well, thank you very much, Laura, for spending some time with us today. And like I say, we'll put those links into the show notes. But I think all that remains to be said is to go and enjoy, I think, possibly a bit of sunshine and a bit of school tag rugby.
I know. Yay. The rain has stopped and the sun has come out, so it's all good.
Just about, yeah. The floodings hopefully will subside. But yeah, thank you very much for joining us. And maybe we'll get you on in the future for an update at some point.
Absolutely. Right. It was lovely to speak to you. Thank you very much.
No problem. Bye-bye. Thanks for listening to the Faculty Focus podcast. If you like the episode, please share with friends and colleagues. You can also like and subscribe to the show and perhaps even leave a review. Clinical education can be tough, but we're stronger as a community, so if you have an idea for an episode or would like to come on and talk to us, do get in touch via email or Twitter. Details in the show notes. The Faculty Focus Podcast, Community Development Showcase.